Thank you all for joining us on this Friday evening, and we are just waiting for a few minutes to allow more people to join before we start discussing this case, and hopefully we are able to take it further and benefit the patient because this case is currently still being evaluated, discussed, and treated. So inputs from everybody will be welcome. So Dr. Rajiv, who is a good friend and a very experienced ENT surgeon, has kindly consented to be one of our discussants until Dr. Anirban can come. But Dr. Rajiv himself has immense experience in ENT. He was on the faculty of Ramaya Medical College. He was the head of Raj Rajeshwari Medical College. And now he's a very successful practitioner in one of the corporate hospitals in Bangalore under the Manipal group. So I think we could start the discussions. So let me just set the context. Many patients of vertigo who come to us are actually those who have clear cut diagnosis, clear cut findings, and can be treated immediately and very satisfactorily, both from the surgeon's point of view and the patient's point of view. However, there is a large group of patients who are not so clear cut, and you have a lot of um, problems in establishing a diagnosis and treating them. So, recently we had one such case, and I want to invite Dr. Anusha to present that case. She will be helped by Shifali, who's our clinical audiologist. But before we discuss this case, I would uh, like to hear something from the people um, who have checked in. Anybody would like to unmute and give us a feel of how many cases in your OPD in vertigo practice are clear cut and how many of them are ones which leave you with some degree of doubt or confusion. So maybe I would start straight away with asking Dr. Anusha. Dr. Anusha, in your ENT practice, how many patients of vertigo can you confidently say a clear cut, clear diagnosis, clean treatment, happy when they leave your OPD? And how many of them you have to visit repeatedly, you have to investigate repeatedly? Dr. Anusha?
Yes, sir. Like we all know, vertigo itself is a complex symptom. So generally, I feel like only 50% of the cases we can go to directly diagnose a case like with BPPV, and if there is uh, like definite vestibular asymmetry or vestibular dysfunction. So those cases we can diagnose directly, but others generally it will be like a mixture of all the diseases. So mixture of there will be some migraine component, there will be some vestibular dysfunction. So all these are mixed up, and it will be difficult to diagnose with the history, and also sometimes even though if we examine the case also, if after examination, generally we could it will be difficult to diagnose a case with vertigo.
So,
So
Dr. Rajiv, could you come in on an audio and also, explain or elucidate what is your experience with vertigo? How often do you feel you get a clear-cut diagnosis?
Yes, sir. Thank you. I get a clear-cut diagnosis in majority of the primary cases of vertigo. But
Okay.
what happens is I get many patients who are seen by the neurologist started on medication and then referred once the scans are normal. In that
Okay.
situation, under the influence of medication and after several days of disease progression, it becomes little tricky to manage the case. So that's the place where I feel most of the time we have a diagnosis which is not clear.
And what do you do for these cases? Do you call them back, or do you treat on a gut feeling? How do you usually deal with these
So
cases?
I prefer not to treat on a gut feeling because they've already been treated by the neurologist empirically. I
Yeah.
usually try to taper and stop the medication and call them back. And
Okay.
sometimes it's useful to have a second sitting a few days later when the
Okay.
patient is also more collected and they would have thought about the questions we have asked previously. Sometimes
Okay.
more useful information is obtained on a second.
Second visit.
Hmm.
So as I said initially, we had one such case which was not amenable to an immediate diagnosis, and I would therefore invite Dr. Anusha and Shifali to together elucidate the case. You could reach up to the differential diagnosis and stop there, and we could discuss. And hopefully, if Dr. Anirban is there, so Dr. Rajiv and Anirban could, give us the benefit of their experience, and then we could go back to whatever you have done in terms of reading before we reopen the case for discussion. So, Dr. Anusha, please, you may
No, sir.
start.
Thank you, sir. Sir, are you able to see my screen, sir?
Yeah, go ahead.
Presentation?
I can
Okay.
see it. Yeah.
Yes, sir. So, we are straight away start with the case history.
Yeah.
So, we had a 40-year-old male patient. He is working as an IT consultant from Maharashtra, presented with non-rotatory disease spells. He's particularly telling that he's feeling like those spells like lightheadedness and occasional short spinning sensations, which is lasting for few seconds to minutes, and the frequency about several times a day since 2 years. He's telling after having COVID infection and recovered from COVID infection, he's having all these symptoms. And it is these spells are associated with tilting of visual field and involuntary spasm like movements of neck muscles. So these kind of movements he is telling. At first, he didn't see any trigger. He didn't understand what triggers the movements and these spells. After some time, he noticed that these movements and these spells, disease spells, are triggered by neck movements, especially flexion of neck and also extension rotation to the towards left side. So now he is trying to induce those movements by flexing the neck and also rotation towards the left side. Apart from that, no other neurological or neurological symptoms he is having.
So, could you just show that video again? I think Dr. Anirban has come into the room, so we can just show him the video again. So, briefly, this is a case who had COVID and then developed these symptoms of non rotatory dizziness with
Yes.
a peculiar spasm of the neck muscles triggered by movement. Could you just play that video again? So, this is almost like
Reflexing.
a tick or a
Yes.
spasm, and he is very much aware that it is happening. Yeah, go on.
Yeah. So, if we see his previous medical history, as per his narration, he was completely all right up to the COVID phase. After recovered from COVID infection, he is getting all the various problems as per his narration. Like in 2021, he had visual impairment for which he was diagnosed to be having central retinal vein occlusion in the right eye, which was treated conservatively with blood thinners, but he is having residual visual handicap now. And another thing is persistent neck pain he is having, for which he underwent neck physiotherapy, which was partially relieved now, but there is some neck pain now also. And recently, he's noticing excessive sweating in the night without any fever or chills and fever. So, from this history, we can know that he needs complete thorough neurological evaluation, and also as he is mentioning lightheadedness, so cardiological evaluation also is needed. So thorough examination was done, which looks normal, like neurological examination of higher functions, cranial nerve examination, motor system and sensory system, cerebellar functions, reflexes are normal, and also cardiological evaluation looks apparently normal. Coming to balance and vertigo evaluation, gait was normal, and standing test for 1 minute, he is able to stand without much swaying, with open eyes, even closed eyes, and on firm surface and on foam surface. He is able to stand for 1 minute. On Unterberger stepping test, there is no deviation. It is normal. And head impulse test we didn't perform as he is having much apprehension on sudden neck movements. So we have done VNG for him video nystagmography, like where saccades were normal. Smooth pursuit, he's having mild saccadic smooth pursuit in vertical plane. Optokinetic responses were normal, but he's having excessive subjective discomfort during the test. And he's having mild spontaneous upbeating nystagmus without fixation. Here we can see like SPV of about 2.2 degrees per seconds and occasional upbeats in spontaneous dark. And again, gaze test, post head shake, post hyperventilation, there is no much difference of nystagmus, but we can observe, we have noted that increase in intensity of this previous upbeating nystagmus along with subjective lightheadedness and involuntary neck movements were noted in various head positions like your right and left pitching backward, and also particularly in it is more in Dix-Alpine test right and left. We can see here, like as long as the supine head extension with the head rotation towards right or left is maintained, that time he is having this increased intensity of upbeating nystagmus, along with he is having that subjective lightheadedness and also involuntary neck spasm like movements. In Dix-Alpine left, these upbeats are associated with mild left horizontal component also. So remaining all tests were normal. Subjective visual vertical also he performed normal. So from these findings, we can understand that there is a spontaneous mild upbeating nystagmus, which is like increasing in intensity in various head positions, and also in particular extension rotation. So it is like we are having suspicion of because it is increasing on extension and rotation. This is the critical point where we'll test for VBI, vertebrobasilar insufficiency. We'll do generally extension rotation test. Here it will be critical position. So same presentation is there here. So that's why we have suspected there could be some VBI. So that's
Okay.
why he underwent various other investigations also.
Would you just stop for a minute and let's just try to get Dr. Rajiv. Dr. Rajiv, having seen these findings and having a history that all these things started after a COVID illness, my first question to you is how many patients have you seen of vertigo whom you could attribute it to a COVID like illness?
Coincidentally, last couple of weeks, I have had 3 to 4 patients who had a severe flu-like illness, followed by dizziness and hearing loss. And the physician suspected a COVID-like illness in almost 2 or 3 patients.
Okay.
Um, the many patients do come with a mild viral infection. COVID, as you know, sir, has a wide clinical presentation. So
Right.
we cannot rule out COVID being the culprit in many of these cases.
Okay. Dr. Bishwas, if you are on the thing, I'd like to ask you a question of what do you think is the relationship of COVID and these kind of illnesses?
See, it is very difficult to link. It is very, very difficult to link the COVID with this. If the patient is having nystagmus, this patient,
Yeah,
as I presume, this patient has got a upbeating nystagmus, nothing
yeah,
else.
yeah,
Now, the upbeating nystagmus, to relate that to some COVID thing and whether it is due to something else, it is impossible to say. It may be a coincidental occurrence, or there may be something completely different. But which part of the brain will cause an upbeating nystagmus? And there, what is the documentation that we have that any COVID abnormality, germ, can reach into the cerebellum or be there to cause any upbeating nystagmus? I don't think we have got
enough
enough
evidence.
of
Yeah,
evidence to say so.
yeah.
So COVID
The
to 90,
patient,
about
yeah,
80% of our population has
yeah,
had COVID in
has
some
had COVID.
time of their
Yeah.
life.
So
So
there
it,
is one
and
point in the
later on,
history, sir.
linking to COVID may not be
Yeah,
correct.
no, so anyway, we're just opening up the discussion. So there's one point in the history that the patient had central uh, retinal vein occlusion
Yeah.
and definitely had residual visual handicap. So does that point to a small vessel disease, which could therefore be something to do with COVID? Because small vessel disease is known in COVID. And also, I mean, we're just working right now in the clinical phase before we go further. But could blood thinners itself have caused problems like this? Could these be associated? Open question. I know we don't know, but I'm just asking.
See, until we have a direct evidence that this can cause this, it is not, I think, rational
Rational.
to link it with that.
Fair
You'll have to
enough.
then tell me
Fair enough.
that how does COVID affect this, but or say small vessel disease.
Yeah,
Small vessel disease, so many other people are also having, but
correct.
they are not having upbeating nystagmus. And
Correct.
there are patients of upbeating nystagmus who do not have small vessel disease.
Correct.
So to link them until you have a definite evidence that okay, this causes this molecular change by which in this particular area of the brain it can stimulate and cause upbeating nystagmus. I would
So
not want to
correct. So you don't
directly accept it.
you don't want to go
That is the
into
only reason, nothing else.
you don't want to go into
It can be linked, but
conjectures.
then difficult to correlate.
Correct. So you don't want to go into conjectures. You want to be sure before you go ahead. The other point was his neck movements causing these symptoms and the spasm of the neck muscles. These are the two other peculiarities in this case. So, neck movements causing these symptoms, would you favor a vascular origin or would you think of cervical induced vertigo? One and two, what do you make of these spasms? I played the video again for you. I hope you saw that.
Yes.
Uh, So what
See,
these are two
I
things
have seen
which,
the videos.
yeah,
Point is that the neck movement, if they are, how are you understanding that this neck movement is causing this vertigo? First of all, symptomatic. Yes, okay, agreed. But is the neck movement actually increasing or decreasing the nystagmus? What can happen is that in cervicogenic vertigo or in cervical vertigo, whatever cervical dizziness, first of all, it is not something which is accepted by everybody. Number one. The Barony Society guidelines on cervical dizziness, that is the term used by the Barony Society, they have very specifically mentioned that they have not been able to come to any conclusion whether anything like that exists. And these are the diagnostic guidelines for cervical dizziness, and this is the treatment for cervical dizziness. That this Barony Society guidelines has very clearly mentioned that. And they have also written that many of these can be actually vestibular migraine, which is presenting like that. And they've shown us reasons how the trigeminal nerve centers can be involved to cause symptoms similar to this. Now, what can happen is that the neck muscle spasm can definitely stimulate the cervical proprioceptors. That will cause not nystagmus, that is expected to cause some head ataxia. Means say disbalance of the feeling of disbalance of the head on the shoulder. Not exactly any head spinning or vertigo or any nystagmus per se. So that is what I would make out of it.
Okay, good.
Difficult to link.
Yeah, fair enough. So I think that is what we expected from you to give us an overview. Anusha, please carry on.
Yes, sir. Other investigations, audiometry showing mild SNHL, particularly in high frequency on left side. MRI brain is having cyst in the left capsuloganglionic region, likely and prominent perivascular Weschow-Robin space. I don't know the significance of it, but yeah. MR angiography is showing dominant left vertebral artery, hypoplastic V4 segment of the right vertebral artery. MRI cervical spine is showing loss of physiological cervical lordosis with multi-level disc desiccation changes. And there are asymmetric disc bulge of C5, C6 intervertebral disc indenting the anterior CSF column in the right C6 nerve exiting route. So, so there are cervical spondylosis changes also, and along with that, there are multiple soft tissue lesions along the subclavian vessel and right internal jugular vein. Likely, there are multiple lymph nodal enlargements. So, this is an incidental finding. With this, uh, like uh, with this incidental finding of multiple lymph nodal enlargements, he was advised to take CT neck, chest, and abdomen also. And it is showing multifocal pathological lymphadenopathy of cervical, mediastinal, and intra-abdominal likely proliferative disorder like lymphoma. So, with this, he underwent a transcervical excision biopsy of level 4 right lymph node, which was done on this November 1st. And histopathology revealed that he is having non-Hodgkin's lymphoma of classic follicular type. Tumor cells are positive for CD20, 10, BCL6 and 2. So, but his dizziness is still present. So for that, paraneoplastic profile was done as there is non-Hodgkin's lymphoma. So there could be some, as we have seen in previous VGR, like there is paraneoplastic cerebellar degeneration with ovarian malignancy like that. So this lymphoma could cause maybe a paraneoplastic syndrome like dizziness. So that's why to rule out that paraneoplastic profile was done, which is showing negative. Yeah. So we are ruling out the immune mediated cerebellar degeneration or encephalitis or neuropathies.
So, so now let me just go to the next slide and we'll come back to this. So right now we have only two clear-cut possible causes for his symptoms. One we have put as a catch-all term cervicogenic vertigo, which could be either due to neuropathy or due to some other lesion of the cervical cord, because we saw a lot of disc changes and disc prolapse, etc., etc. Could there be a kind of a neuropathy, either of the lymphoma or the you know uh, pressure from the cervical cord? One option. The fact that the V4 segment is hypoplastic on one side, could you be dealing with rotational vertebral artery occlusion syndrome? That is the second differential which we considered. Again, would like to invite our panelists to give opinion. At this level of investigation, you know the patient has a lymphoma, you have the history, you have the VNG findings. Do you feel we are any closer to a diagnosis, or does this patient require more investigations? Rajiv, would you like to start with this?
Yes, sir. Sir, rather than straight away calling it COVID-associated vertigo, The symptoms are suggestive of an immune or demyelinating disorder. From the beginning, if you see, he had symptoms like sweating in the night, and he has neck pains, and he also had a central retinal artery occlusion. So it would be more appropriate to call the initial diagnosis as an immune-mediated disorder causing vertigo. And of course, viral infections do worsen the inflammatory diseases. So that might explain his history that during COVID it increased. Maybe it may not be a direct causative factor, but of course it might have worsened his inflammation. These are all speculations we can
No, I
only
get you.
make
So
at this
you are
point, I
suggesting that this
suppose,
is,
without evidence like sir
yeah.
saying we should not be
Okay.
making it a definite diagnosis.
Yeah. So you are suggesting some kind of,
Of course, having the
go on,
it's possibly an immune
mediated,
mediated
and you don't want to
disorder,
call on
which is
paraneoplastic.
leading to
So you don't want to consider the paraneoplastic immune.
inflammation, demyelination. These are the things which happen in
Okay.
immune-mediated disorders.
Fair enough.
So they will explain majority of the symptoms.
Okay.
Paraneoplastic diseases, one of the component is inflammation.
Yeah.
So
So
paraneoplastic syndrome is also partly inflammatory. I mean, it is inflammatory and immune mediated.
okay.
I think we had this discussion in one of the previous
Correct.
presentations where
But that patient had very
paraneoplastic
clear-cut,
syndrome was
yeah,
discussed.
that patient had clear-cut abnormalities in the workup.
So broadly, we can call it as an inflammatory or immune-mediated syndrome, and paraneoplastic disease can be the final diagnosis if there is nothing else found.
Okay. Dr. Bishwas, what would you like to tell us about this? I know it's very incomplete, but
No,
this is what we
what
have
is,
at present.
whether it is a rotational vertebral artery occlusion syndrome,
Yeah.
Yes, so that's why
that
I would
by
prefer to call it
requisite
an
radiological imaging,
inflammatory
imaging
disorder
studies, that can be
causing
well settled. Yes or no? So if you think about it, then we can have the requisite imaging study for rotational vertebral artery occlusion syndrome, where you change the head position and you do the arterial study, and that is a very specific standard thing by which you can identify it. Whether it is a cervicogenic vertigo and whether that is causing, that spasm is causing ataxia of the head, very difficult to say, because for this you have to do a therapeutic trial with muscle relaxants and all and see if that is changing. And whenever I am in a position like this, what I do is that I try to clinically test it. How do I clinically test it? I stand behind the patient, make the patient sit on a revolving chair with handles, and then ask the patient to close the eyes. I stand behind and give a cephaloid traction to the patient's head. And then my assistant turns the revolving chair like this. See, when the head is like this and the chair is turned like this, then, and the head is held straight ahead, straight up with the eyes closed. What are you doing? By closing the eyes, you are eliminating the visual input. By uh, uh, the other proprioceptive inputs are also stopped, because you are sitting on the same place, and since you are not moving the head is held like this. Only the trunk is being rotated with the head held in a cephaloid position. So if that generates any giddiness or that generates any dizziness, or you can find any nystagmus, only then I would relate it that it is originating from the deep proprioceptor muscles of the neck. The deep neck muscle proprioceptors. So that is the only way. Otherwise, it is difficult to say. And in many of these patients, when I'm not even sure, I ask the patient to have a MRI of the cervical spine and specifically ask the radiologist to find out if there is any contraction or any spasm of the deep neck muscles, specifically I specify the suboccipital muscles. So that is what I do about these things. And then if there is anything, then I would put the patient on strong muscle relaxants, and whether the muscle relaxant gives them some psychological issue or not, or the neck pain survives, so say neck pain subsides, and that gives them some happiness. I would not say freedom from symptoms, is difficult to say, but many of these patients with all these things, a lot of things have been done. Some patients say that yes, they are much better now. Very difficult to say. See,
So,
the point is that for me, until I get a evidence-based thing supported by scientific documentation and I am seeing it clinically, I would not want to conjecture on this can happen, this might have happened, this may happen.
correct.
So, and
So my
even if you know that it is caused by, and one good thing that has been done by Anusha is that she has done the paraneoplastic study and that has been ruled out. So if that is ruled out, the next thing that we sometimes do, because I am in a neurology hospital, so I've got all these facilities. So we send the patient for a CSF study of the for the paraneoplastic profile also. So I
okay,
think 1 in 20, I would be getting a patient where the paraneoplastic profile of the blood is normal, but in the CSF study, the paraneo 1 in say 30-40. The
okay,
paraneoplastic profile has been positive in the CSF study. So
okay.
that the neurologist will be knowing much better, and I don't think I am the right person to talk on it. And these things we try to just load off our heads and send them to the neurologists. So whatever they think
Yeah.
best, at least I escape my duty.
No, so but follow-up question: how often do you see the bow hunter syndrome or the neck position related thing? Is it a very common thing?
No, not very common where you can get evidence, but a lot, most of the patients who come to us,
Yeah,
they will come and say that I have got a neck pain also and I've got this thing also. So
yeah,
that is there. But then to find evidence for it and be sure about the diagnosis,
yeah.
very rare.
Okay.
Where I have found evidence that it is there, and I'm sure that this is something which is originating from the cervical region.
So, do you recall in your practice being able to demonstrate even radiologically actual mechanical compression and diminution of blood flow?
No, it is not. See, let's get one thing very clear. We have got such excellent collateral blood supply in the brain
Correct,
that of the 4 blood vessels, the 2 carotids and the 2 vertebral arteries, even if you
correct,
ligate one completely, nothing much happens.
correct.
And so many people know without any symptoms have got hypoplastic vertebral arteries and all. They do not have any symptoms. So our collateral supply is excellent, and we get patients just for the heck of it. We sometimes there's nothing better to do, or everything that could have been extracted from the patient has already been extracted. Vestibular function test, radiology, everything has been done. So we're not left with anything else to do new. Or the patient has come after I am the probably the 57th doctor in the line, and everything has been done number of times. So one thing I can find out which has not been done is carotid Doppler. So do that
Ah,
nonsense of carotid Doppler on that patient. And sometimes you find that yes, carotid Doppler is showing a 75%, 80% blockage. Now, how much that is related to this and whether that can cause symptoms is something beyond my understanding.
fair enough. So, you're,
So these are
you're a
things about which a
skeptic.
lot of things can be discussed and written,
Correct.
but then I think we leave it at the discussion level only and not try to aggressively do anything about it for the patient.
Fair enough. So, going forward, this patient now is uh, on a horn. We'll come to this theory discussion later. Is that okay? You want to discuss anything more, Anusha, before we start discussing what happened to the patient?
No, sir. Please carry.
So briefly, we are at this point now. The patient, because of the fact that he's been diagnosed as lymphoma, everybody has said that, treat the lymphoma and then hope that the vertigo subsides. He's a little skeptical. He feels that the vertigo is something which is primary and the lymphoma is something which is an incidental finding. What do you think, Dr. Rajiv?
It's very difficult to disconnect the body into systems like that, sir.
Yeah,
He needs treatment for that also, but he should understand that since there is no clear-cut diagnosis,
yeah,
we should take things one step at a time, probably.
okay,
Maybe I would also get a CRP done if it's not done for this patient.
okay,
Serum CRP.
okay. I mean, you're thinking of inflammatory
Yes, sir.
uh, disorder.
Yes.
Okay. And Dr. Bishwas, what would you think now? How would be our line of approach?
See, first of all, is that the lymphoma will have to be treated in its best possible way as a
Correct,
separate entity.
correct. But that would be a
So whether treating the
chemotherapy.
lymphoma is in any way going to regress the vestibular symptoms is difficult to say,
Correct.
because it is nowhere proven that lymphomas can cause vestibular issues. See, one case report here, one something over there, published in the Neurological Journal of South Bombay, or Neurological Journal of North Chandigarh, it doesn't mean anything much. So
Correct.
some nonsensical thing may be there. Question is, can we rationally explain it? If we cannot rationally explain it, I think we should not pursue it on those lines. Treat the lymphoma separately. Let the
Correct.
hematologists and other people do it, and we will treat the vertigo or imbalance, whatever is the patient's problem, or head ataxia. See, I am not very clear on this patient, whether the patient was having a spinning sensation or a head ataxia, that means instability of the head, or instability while walking. Because I think I had missed that person thing. What was the patient's primary complaint? The patient had mild upbeating nystagmus.
Yes.
But whether that upbeating nystagmus of 2 degrees is enough to cause symptoms to the patient is also, I'm saying this from a completely practical view. Whether that is expected to cause symptoms is difficult to say, number one. And number two, how do you know that that upbeating nystagmus was not there for years before? It may have been there for a long time before also. And if a eye movement is there for a long time, then the brain adapts to it. And the brain then ignores the images when it is off center. Like what happens in congenital nystagmus. The eyes are moving, but patient doesn't feel the vertigo because the eyes only catch. It is only that information is transmitted to the brain when the eyes are in the center. And so the patient is not, though the eyes are moving, the patient may not be feeling the vertigo. So see, these things are very difficult to say whether that small 2 degrees upbeating nystagmus was actually causing the symptoms that the patient is saying.
Yeah. The
So
only
all
the
these things, there is
spasm of
a
the
lot of
neck.
debate that can go into it, and but then we need to understand that what are we actually dealing with.
Yeah.
And I would, as for the treatment part, I
Yeah.
think I would put the patient on something like baclofen
Okay.
and baclofen, clonazepam, and try and see if anything happens. Definitely not that our common that combo of 13 sugar and semitel. Definitely not anything like that. But a trial with baclofen, gabapentin, something like that, may often help in these patients.
And
I think that's the
baclofen
best thing to do.
as a parenteral, oral, or intrathecal, how would you like to put it? Baclofen treatment.
Baclofen, we usually give orally only.
Oral. Okay.
We're not been so adventurous to try any other route because, see, with these drugs, you're not sure whether that drug is actually going to act or not.
Yeah.
And so if any, if we mess up, we are in private practice, so if you mess up
Correct.
something, then
No, but I think there are baclofen tests. Something like you have your um, a drug test to see
yeah.
effectiveness. So baclofen testing, of course, is a described thing also by which you can give it parentally and see how much response there is. I think it is used for these spasms and your Parkinsonism tics, where you give baclofen as a trial. So maybe you could ask a neurologist to give a baclofen trial here. And if
That
it
can be done.
works,
But you
that,
see, Dr. Ravi, one thing
yeah.
is that in the hospital, in our hospital, I find that many of these patients, right, left, and center, they give Botox injection in the cervical region for different
Ah,
reasons, cervical dystonia, fistula. So I have asked them that, you see, we talk so much about cervical spasm causing vertigo. When you're giving the Botox injection, before or after, does the patient ever complain of any vertigo or any head stability? Nothing happens. So they give many, many, many. But no patient ever says that after giving the Botox injection in the, see, you are giving it superficially. Botox you are not giving very deep.
mm,
And cervicogenic vertigo, if at all, it is expected to happen by spasm of the very deep neck muscles.
mm.
You're not giving it that deep, but anyway, uh, this does not happen. So you see, these are a little messy things about which even the Barony Society could not come to a conclusion. And so I do not think we have anything much more
No,
to
fair enough.
add.
No, I just that's great. So I think we
So
have
let
some
the
inputs that we'd
lymphoma
have
be
to.
treated separately, and
Yeah.
we try our luck with baclofen, clonazepam, things like that.
Okay.
That may or may not help, but then it's worth a try.
And we can redo the clinical testing with rotation of the head to see whether there's a chance that we could pick up some symptoms due to
That
vertebral
is what
artery.
I do in my clinic, but
Yeah.
then I have never had the time to write it out and publish it somewhere. That we have not done. But then I had once presented it many years back in the Neurology Society meeting, and there it was very, very well accepted. So that is something which
And
scientifically
as
it is logical.
logical. And as Dr. Rajiv suggested, we could check for C-reactive proteins and we could explore the
Of
fact
course.
whether you're dealing with an autoimmune or an immune-mediated problem.
Yeah.
So that is, I think, our way forward. Uh, Dr. Anusha, you had some theory reading of this which you would like to share?
Now, with the treatment, has the patient's vertigo or balance
No,
disorders come down?
no, he doesn't feel that there's been any response because this lymphoma became a sidetrack. So he was going around from pillar to post trying to establish the lymphoma. We managed to get a couple of tests done, but I think he's still on a follow up. The thing is, he's not in our state, he's out of state. So we are practically chasing him by phone. But he's motivated because he's a IT
Oh,
professional.
yeah, yeah. But then see, with these patients, is that until they chase you, better to keep them away. Because there's nothing very
Oh,
logically
I was
that we
hoping I
can
could
do
send
to
it to
save our
Calcutta.
skins.
I was hoping I could send it to Calcutta. So,
The last place we would ever welcome him.
okay, Anusha, please carry on. Just tell us what you have done in your reading. I think you've done exhaustive reading, so we'd like to hear the results.
Yes, sir. In short, our patient is actually completely normal when he's in neutral position, like neutral position of neck, and also while standing and sitting, he's completely normal. Uh, Subjective feeling of normalcy, and he's having symptoms whenever he's flexing his neck and also rotation his to mostly towards left side. So for that, I thought it might be like cervicogenic vertigo caused by proprioceptive disruption due to neuropathy. As if I like after a thorough like reading of articles, I found some effects of lymphoma on peripheral nervous system. Like there will be nerve infiltration. It is reported in non-Hodgkin's lymphoma, which can cause this painful muscle spasms. So maybe it could be due to, I thought maybe peripheral neuropathy is causing this proprioception disruption, which is leading to cervicogenic vertigo, as he is having those symptoms and dizziness. In particular, he's saying it as lightheadedness. So these symptoms and are with neck movements only. So it may be mostly as cervicogenic vertigo. I thought that's it. And another possibility is as he's having increased intensity of upbeating nystagmus, like a sign or like a finding in examination. So it could be due to artery occlusions also. So rotational vertebral artery occlusion syndrome or Bow-Hunter syndrome is a next possibility. So in this, it's a rare syndrome which will cause the vertebrobasilar insufficiency due to blood mechanical compression or occlusion of the vertebral artery during rotation and or hyperextension of the head and neck. So our patient is having loss of physiological cervical lordosis and also multiple disc changes and spondylosis changes also. So there could be some compression while he is having neck movements like rotation and also extension. For that, yeah, loss of cervical lordosis have leading to Bow-Hunter-like syndrome. It is there when in one case report. As we all know, the gold standard test will be digital subtraction dynamic angiography. So here we have to do the angiography while turning the head also to see the compression of the artery while movement of the neck. And as it is invasive test, so screening can be done with a dynamic vascular Doppler ultrasound or transcranial Doppler in different head positions. And as Anirban Biswas sir told that, like clinical tests like this cervical torsion test and also smooth pursuit test on neck torsion, these tests also will give a clue about cervicogenic vertigo. So treatment of this Bow-Hunter syndrome will be conservative treatment with antithrombotic medications to prevent.
Which he's already on thanks to
Yes,
his
yes.
retinal occlusion, right?
Yes, yes.
Yeah.
And limiting the head rotations. In some cases, they need a surgical intervention to remove the compressing structure also, which might be osteophyte or compressing ligament or
Okay.
disc herniation. Like, so our patient needs a thorough workup on that. Like maybe sir is telling CSF paraneoplastic profile.
Yeah.
CSF
So
also.
I think going forward, we'll have to try baclofen, investigate further in the lines of the expert comments of Dr. Rajiv and Dr. Anirban. Maybe do some more clinical testing. And maybe down the road, we would revert back to you with this, with a further progression of this patient's whether he has resolved. I think what would be most interesting is whether all his symptoms would go when his lymphoma goes, because that's a kind of hindsight diagnosis that this was due to the lymphoma. Because NHL in a young male like this, though its prognosis is not as good as otherwise, but definitely it's amenable to disease-free survival, sometimes to cure. So we need to wait and watch and on this patient. If can, I'm going to throw this discussion open to the audience. Does anybody in the audience have similar cases in their experience? Would they like to comment? Would they like to give ask some questions? Because you have two eminent panelists and you have a team which has worked up this case exhaustively. Anybody who wants to come in can unmute and ask a question. Shifali, would you like to say something?
This is yeah, yes, sir. So basically, we now know that rotational vertebral artery occlusion or say Bow-Hunter syndrome is a rare entity, and because it is rare, we generally don't think of it in the first go. But that is where we miss the patient. So when the patient is coming to any professional, they seek a diagnosis, they seek the identification of their problem. And if we miss out on certain tests, we will clearly lose the patient, because he will now next go to somebody else, and some other doctors might just prescribe a medication only for symptomatic relief. That shouldn't happen. So even though it is rare, we should keep this point in mind, and based on take a clear
So
cut
what
decision.
what test would you like to do?
Sir, our basic PNG and some other parameters like smooth pursuit neck torsion test, we have it in our system, and the rotational chair test, as the doctor suggested. This would be enough, but definitely we should also take support from imaging studies, so that we can correlate our findings and be able to tell it to the patient, and
Right.
maybe give some treatment based on that, so that now knows he's with the right professional, so that after that, if any other workup is there, he'll be able to easily do it for us if it is necessary.
There is a question from Dr. Sona. Would you like to pose the question yourself, or shall I read it out? Dr. Sona? So Dr. Sona is asking the question, would physiotherapy help to um, make the muscle spasm less? What do you feel, Dr. Rajiv?
So if you're suspecting a vertebral artery occlusion, we have to be very careful advising physiotherapy. So probably if you're investigating him for vertebral artery occlusion, and if it is negative, then later on physiotherapy would be useful. But I
Okay.
wouldn't do it right away.
So what would you understand by physiotherapy? It was the standard isometric isotonic exercises, or would you like to give some form of deep relaxation with infrared or ultrasound or something like that?
I generally don't intervene in the physiotherapy personally, but our physiotherapists where I work, generally they give IR or laser stimulation and heat and cold packs. These are some of the things which they do. Um, I think they would be more competent to answer the question than
Yeah.
myself.
Yeah. So there was a brief question which I could not read in detail. Uh, could I get to see that again in the chat?
In case of vertigo, does all the patients require a cervical X-ray need to be done?
So, Dr. Bishwas, would you like to take that? Would you like just to do a cervical X-ray, or would you like to do a Doppler ultrasound? Would you consider this a routine test just to be done for completion, or would you like to take it as a mandate? Dr. Bishwas, if you're not here, Dr. Rajiv, would you like to take that?
Pardon, sir, can you please repeat the
Yeah.
question?
So the question is that would you do a case of cervical X-ray as a part of a protocol of examination for vertigo?
Not as a part of a protocol for vertigo, sir, but this patient came with a complaint of neck pain.
Correct.
So that would be one of my initial investigations. We can't treat vertigo in isolation from other systems.
Correct.
And initially, I would have got an X-ray done. And
Okay.
if the problem persisted, I would have even involved my orthopedic colleagues for the
Okay.
evaluation.
Okay. And in the same line, would you then ask for a Doppler?
So far, I have not found Doppler to be useful in any patient, to
Okay.
be frank with you, sir. So I'm very skeptical about vascular compression causing vertigo. And
Okay.
I would feel that in case it was a vertebral artery occlusion, the symptoms would be more in terms of loss of visual acuity or blackouts, because the posterior circulation is the one which is predominantly affected there.
Hmm.
So I'm still not convinced. Of course, it's a very rare condition, and I have not had any experience with it. So
Fair enough. Fair enough. Dr. Praveen, would you like
Evening,
to?
sir. So
Hi,
nice
how are
to be
you?
back, sir. I'm feeling like I'm in VBAM class again.
Yeah, especially having Dr. Bishwas there with his skepticism, right?
Sir,
Good.
just wanted to ask, like I'm in my clinic also, I'm seeing patients like aged patients around 80, 70-year-old patients who are bound to have and who have a cervical X-ray already, in which there is degenerative changes, and they come with like the same care, postural changes, and we don't get any symptoms like any vertigo as such. So mainly they are of dizziness and lightheadedness or head heaviness, basically, as to say, or on their words. These are their basic complaints, and that too is more on the head extension or deep head hanging or in the Dix-Hallpike positions. So, and it relates to, I've not seen any in any malignancy as such, but in old age patients. So they come with the X-rays. So what to do next? Because they are like symptomatically, we do usually if symptomatically is there, then I give the this one, and they usually don't come back. So whether it is helping or I should follow up, because I tell them to come back and they don't come back means they are fine, or
Yeah.
their symptoms, like if they are chronic, there it will be like I'm giving the same treatment as the other doctors. Is any
No,
approach
no.
in
So,
that X-ray with cervical X-ray?
yeah.
If they come with cervical X-ray, what to like? We have to refer to neurosurgeon again, that it may
No.
be because of this rotational artery,
Okay.
which I have
No.
not encountered yet, but
Great. No, so I think I would also be very skeptical of the need for surgery to knock off osteophytes and all this stuff, because the exact compression is something which I'm a little skeptical about. But I mean, definitely, if in a test, a torsion test, you find something, then you should not ignore it. I have, before we used to test for this torsion test, I have used soft collars effectively,
uh,
because that prevents sudden movement. See what happens, many of these patients, when they're walking along a road, for instance, they suddenly hear a horn, they turn rapidly, and then they tend to feel dizzy. So
yes.
I find soft collars prevent the rapid movement of the neck and has some degree of symptomatic relief. So that's the only thing I would suggest.
And in
Uh,
aged patients, that would also benefit with
yeah,
the cervical
and I'm also
convolution.
a good. I mean, I'm fairly happy with explaining, isometric and isotonic exercise of the neck to stiffen the neck muscles, because again, this is I can't really quote literature on it. These problems can occur when the individual vertebrae slip on each other,
Uh,
because they're very very small muscles stabilizing the cervical, vertebral column, and these muscles need to be exercised to keep it stiff. So you're trying to induce a degree of stiffness where the neck vertebrae don't slip on each other. I found it to be effective. I don't know whether it's a placebo effect, because you spend a lot of time explaining how to move the head, but just for what it's worth, I can put that up. Dr. Rajiv, would you like to add to that?
Yes, sir. So if a patient has, especially elderly patient has neck pain, it's very important to do a proper vestibular evaluation also in that patient, because I'll just see just this yesterday I had one patient with multiple osteoarthritis, both shoulders operated, having severe neck pain and the severe restriction of movement, complaining of vertigo and difficulty in balancing while moving. So, with a lot of difficulty, I could do a modified Dix-Hallpike test, and I could see that there was a posterior semicircular canal BPPV in this patient. Now, treatment is also a challenge for me because she cannot turn to her left side, and she has a right posterior canal BPPV.
Here's a here's a
Yeah,
small suggestion. We have that chair in our clinic, so maybe one day you could come with the patient and uh,
do the
put
maneuver.
the patient on the chair, so you could make the chair do all the motions.
Yes, sir. Actually, I've sensitized them to that option.
Yeah.
I've given them the initial option to wear a sling and have a physiotherapist do the maneuver. If it doesn't work out, I've already told them that I'll have to refer her to your center.
No, you could come and do it, sir. We'd be welcome.
Okay, sir.
Right.
So in the elderly patients, we definitely have to do a vestibular evaluation and not say it is just because of neck pain.
So you think that these things can coexist?
Yes, sir. They definitely do coexist.
Any role of MRI, like chest X-ray, would not be able to, the any disc changes maximum are detected in MRI, I guess. Whether any role or any beneficial effect of MRI, especially in aged patients,
No,
uh, in
I
this
think the
regard, sir.
problem would be if you want to do dynamic testing in an MRI machine, it will next
Very
to be
difficult,
impossible, you know.
sir.
And generally, elderly patients don't like the MRI machine.
Yes, sir.
It's
Mm.
terribly noisy, claustrophobic, and takes a lot of time. So, but that said, I mean, who am I? And nowadays, newer and newer, you know, iterations of the MRI machine is coming, which reduces the uh, picture capture time, you know. So, who knows? We have another question about beta circ having a role. Oh, now that's a question. Beta circ, anybody wants to take this? Dr. Rajiv? Or Dr. Bishwas, sir, if you're still here.
I have no experience with that, sir.
Yeah, no, that's what I was thinking myself. But I don't see how, when you said this kind of vertigo, are you referring to the cervical, the bow hunter kind of vertigo, or are you thinking of the post malignancy or uh, autoimmune kind of vertigo?
Considering the other symptoms, the atrophy seen on the MRI, I would still tilt in favor of autoimmune dysfunctions. Maybe I'm biased because of my experience. I get a
Yeah.
lot of patients from the rheumatologist in my center.
Ah.
Uh,
So would beta circ help in that case? I mean, this would fall roughly under category of non-specific. I mean, that's my estimate, but I don't know whether you think beta circ could help.
I don't think, considering his symptoms, he would be benefited with it, sir.
I mean, in what conditions would you give beta circ in the first instance?
So beta histine, I would give probably when I mean the classical situations, acute situations when there is a flare up of vertigo as a symptomatic relief. That would be my primary use,
Yeah.
and maybe in Meniere's disease as a pulse therapy. But I don't think it would be of any use in this particular patient.
So I think we've almost run out of time. So first and foremost, let me thank the panelists, Dr. Bishwas and Dr. Rajiv. Dr. Rajiv, especially, I tip my hat to you because when Dr. Bishwas felt that he was pressed for time, you so willingly accepted, which I think was very nice of you. And I owe you one. You could ask for it whenever you want.
No problem, sir. My
A
pleasure.
lunch or
Thank
a
you.
dinner. I think it's your. But anyway, come over. Maybe we could have a chat.
Sure, sir.
I want to thank both Shifali and Anusha for an excellent job. They have prepared well. They have, and we request them to stay connected to the patient and maybe in some subsequent prepare a brief summary so you could share the evolution of this patient's disease so that it shouldn't be just one presentation and that is all. And maybe the suggestions which have been given, we will take home and we will try to get the patient to move accordingly. So thank you both. And thank you to all of them all the audience who have from quite long distances, I assume, temporarily all over the globe have checked in and uh, attended this meeting and listened to, I think, very illuminating talk both by Dr. Bishwas, Dr. Rajiv, and the two presenters. So, thank you, one and all. Have a very good night and have a nice weekend. Thank you.
Thank
Thank
you.
you, sir.
Thank you, sir.